Wait lang, on ko camera ko. So good evening guys, welcome to my stream. Today we'll be taking up pato. So specifically the pato part of the written valida. So swear tayo na walang pictures na pinakita. So kasi sobrang hirap ng part na yan, honestly. So for our first question, wait lang. I need to move this. Thank you. So first question is the molecular subtype of breast carcinoma that has the best prognosis. So um, in this is just a question that asks you about different subtypes. So I put under the four subtypes: luminal A, luminal B, HER2 plus, and triple negative. So HER2 positive and triple negative are self-explanatory. If you know the name, you can get the receptors that will be positive. So HER2 would only be HER2 positive, while triple negative would be negative for ER, PR, and HER2. While for luminal A and luminal B, they are both ER positive. So ER stands for estrogen receptor. They can also be progesterone receptor positive or negative. And the difference would be in the HER2, where luminal B could be positive or negative. And also in the Ki67. So it's Ki67 is a protein marker where if it's present, there would be increased cell proliferation. So this would be associated with a worse prognosis. I also added on the right side the therapies that you should add, the therapies that are best suited for the different subtypes. So since the luminal A and luminal B are estrogen receptor positive, hormonal treatment can work for them. While for HER2 positive, trastuzumab, which is an anti-HER2 antibody or a drug, would be the most effective. And finally, for triple negative, chemotherapy would be the most effective. So the answer would be A, because it has the best prognosis, because it has decreased Ki67. So additional info, the most common cancer in females is breast, but it's only the second highest mortality. The number one is lungs. And then for it's always asked the ductal carcinoma in situ, tsaka lobular carcinoma in situ. So as a quick review, when we talk about carcinoma in situ, it means that it is not yet invasive. It has not broken through the basement membrane. And then under the tables, you can see the main differences between them. For the ductal carcinoma, these are the ones that will present with calcifications, central necrosis, and will usually just affect one breast, as opposed to lobular, which will have no calcifications, no cohesions, and will can predispose to both breasts. And then the an important thing to note when you're thinking about pato is you should really connect this into all the other subjects. So, etong part na to sa risk factors, nilagay ko exposure to estrogen. Kasi, saan natin nakita tong exposure to estrogen? We can link this to OB. Di ba sa OB, palagi nilang sinasabi na a risk factor for increased estrogen would be an early menarche or nulliparity or late late menopause. So there is increased estrogen production over time. And then just for a bit of prep med, so when we do a self breast exam, we do this 1 week after menstruation. And also the mammography screening starts when you're 40 years old. So next question. Um, so this is another important concept na kailangan natin maintindihan sa pato is minsan hindi natin talaga ma-avoid na may mga words na hindi natin alam. And then dahil doon, parang kailangan na talaga natin hanapin yung parang trigger words. So for example, in this case, pag nakita mo agad yung pap smear, nakita mo yung HPV, tapos tinatanong niya ano yung pathognomonic feature, palagi natin dapat iniisip ang coilocytes or coilocytosis. So these are pathognomic cells seen on pap smear that will tell us that the patient has condylomata acuminata. So description are nuclear enlargement, hyperchromasia, and cytoplasmic perinuclear halo. So all of these other cells, nalagay ko na rin yung description para mas familiarize tayo. Pero generally, these are not connected to condylomata acuminata at all. So, para lang ma-shock kayo, ito yung picture ng coilocytes. So, yeah, there's perinuclear halo. So next, So Pato also likes to ask questions na very very difficult minsan ang questions ng Pato. For example, ito tinatanong nagbibigay lang siya ng exposure which is aniline dyes over there was chronic exposure to aniline dyes. And then they're going to ask you what is the cancer that the patient is most at risk for. So here I have a table that shows you the exact exact carcinogen pati ano yung nakakause niyang cancer. Pero a good thing about this question is nagbigay sila ng clue. Binigay nila ang symptomatology being passing out red urine. So parang pag naisip mo, nag-pass siya ng red urine. Baka may kinalaman to sa renal system. Out of all of these choices, si urothelial carcinoma ang pinaka-closely related sa urinary system. So if you don't recall from histo, urothelial cells are the cells that line the bladder and they can stretch. Another word for them would be the transitional cell carcinoma. So yeah, that's why your TESOL would be, I mean, if hindi mo alam tong table na to, which I'm sure ako hindi ko alam when going into this question, ginamit ko lang yung parang clue word or clue symptom, which is passing out the red urine, and linked it to urothelial carcinoma. In case they modify this question and give you other carcinogens, um, nilagay ko na, binox ko na yung others na baka tanungin. Like for example, asbestos can cause bronchogenic carcinoma and also mesothelioma, but more often not bronchogenic carcinoma. Aflatoxins from aspergillus could cause liver or hepatocellular carcinoma, and the alkylating agents can cause leukemia. So medyo mahaba tong table na to. So um, I just really boxed what I think would be important, hopefully. Kasi naman, if they tell you that the patient likes to eat smoked food, parang dahil connected yung food sa stomach, isipin mo na more or less na sa gastric cancer. Yeah, also cigarette smoking, ang dami niyang pwedeng gawing cancer. So kung nag-iossi kayo, medyo maybe consider mag-stop. They could also ask about the different infectious etiological agents of cancer. So obvious na naman yung hepatitis B would cause hepatocellular carcinoma. H. pylori would cause gastric adenocarcinoma and maltoma. So I only box the ones that are not as obvious, and usually ito yung talagang tinatanong nila like EBV and nasopharyngeal carcinoma. Don't forget Burkitt and Hodgkin's, pero parang ang dami talagang cancer na associated sa EBV infection. So next question. So we have a 50-year-old man, and then the symptoms were given this time: jaundice, ascites, hepatic insufficiency. They also were kind enough to give the lab results. The prothrombin time elevated, the total protein and albumin were low, and they even gave us an ultrasound showing a multinodular contracted liver. But what they're asking for us is the most likely liver biopsy. So if napansin nyo, talagang sa pato, medyo intimidating, medyo ang haba, medyo ang dami nilang hinahanap or binibigay sa question. And then, unless sobrang master mo, hindi mo naman masasagot agad. So, kailangan talaga natin i-analyze. So, yung approach ko for studying pato, I mean right now, kasi sobrang hirap balikan nung second year, is parang I would focus on the disease, for example, cirrhosis, and then I would try to remember the whole definition lang. So, disease, sakit, definition ng sakit, and then trigger words. So, pag sinabing cirrhosis, inisip ko, ito yung parang nagkaka-fibrosis, yung liver nadadamage, and then since the liver is a regenerative organ, meron siyang stellate cells that, ito yung parang regenerative cells that can produce more matrix. It can heal itself over time. But the healing is not fully complete, not the best, and it can cause scarring and bulging regenerative nodules seen in cirrhosis. So because of that um, that understanding of what cirrhosis is, parang mas napuput two and two together ko na when they say a contracted liver, parang it's a cirrhotic liver. And then there is bridging fibrosis. Uh, Additionally, for the other choices, para mas ma-understand natin, there's also non-alcoholic fatty liver disease. So from the name itself, fatty liver disease, it starts with fatty infiltration of the hepatocytes. So that's choice C. And then over time, it could progress to cellular ballooning and eventual necrosis. So that's A. So if you knew that, you can sort of rule out A and C. And mas consistent ang bridging fibrosis sa multinodular contracted liver. Finally, the last one, if you really want to be to tackle all the choices, would be the trabeculae of neoplastic hepatocytes, which could present, which is ano, when you hear neoplastic hepatocytes, we always think of hepatocellular carcinoma. And um, sure, hepatocellular carcinoma can coexist with cirrhosis, and cirrhosis could coexist with they could exist together or apart. Um, Hepatocellular carcinoma would not exclusively be linked to a contracted liver. Kasi di ba pag sinabing hepatocellular, parang kapag cancer lumalaki, may mass, ganun, hindi naman magmumukhang contracted. So, I guess yun yung logic dito. Parang important talaga ma-connect mo yung dots for pato. I mean, honest talaga i-master mo, i-memorize mo. Pero, hindi worth it yun eh. So, just to, kasi pinag-usapan ang lab tests here, ito yung maraming functions ang liver. And then marami din siyang tests. And these are always important. Palagi siyang hinihingi pag nag-case tayo. Palagi siya for baseline, for function. Kasi ito rin yung nag-metabolize ng drugs. So we have the liver enzymes. So AST and ALT. They signify liver damage. So they have a pattern actually. So if there's an AST that's greater than ALT, 2:1, we think of alcoholic hepatitis. So, minsan lang ako gumagamit ng acronym kasi nakakalimutan ko palagi yung mga acronym. Pero, so, we make a toast with alcohol, with AST, and then alcohol. If the ALT is greater than AST, we think of non-alcoholic fatty liver disease. So, ALT, lipids. Finally, if we think of biliary problem, biliary disease, we can ask for an ALP and then it will be elevated. So just a bit of it, in case baka matanong, ALP is also elevated in bone diseases, while GGT is more specific for the biliary diseases. But usually ALP lang naman talaga yung in order natin. And then for the function of the liver function tests, the most sensitive would be the PT-PTT because the liver produces coagulation, most of the coagulation factors, and also produces albumins and and TPO, which stimulates platelet formation. So this is a question from the written revivalory meds last year. So once again, this time they're asking you which of the following best describes a liver with end-stage liver cirrhosis. So it's just asking you which one would match a description of cirrhosis the best. And true enough, the question with fibrosis is the correct answer. If you want to go through the others, um, C and D has inflammation and plasma cells. So these are more of inflammatory processes, which are not always present with cirrhosis. While a thickened hepatic plates with loss of reticulin framework it can be non-alcoholic fatty liver disease. It can also be cancer. So it's not specific. So next, this question was actually repeated many times in our written Nevada, in the remeds last year, and the written Nevada last year. So they really like asking about the different ovarian tumors. So in this patient, they actually gave us already the complaint of postmenopausal bleeding, and the patient is 56 years old. So, di ba sa OB, they always tell us if there's bleeding postmenopausal, it's sort of a danger sign. Now we should try to figure out what is causing this bleeding kasi menopausal na nga yung patient. So, what is the main hormone that stimulates endometrial proliferation? And that is estrogen. So, basically, tinatanong lang niya is, anong ovarian mass ang nagpo-produce ng estrogen? Yun yung most likely mass in our patient. So, in the next slide, hindi pa pala yung next slide yun, nakaka-overwhelm. So, ito muna tayo. So, ito yung ovary. And then remember, cancer is defined by what cell line it comes from. So, in the ovary, there are three cell lines that can become cancerous. So, there's the epithelial cell line, which comes from the surface epithelium. There is the germ cell tumors that come from the oocytes, the egg, and the sex cord or stromal tumors, which come from either the follicle or the stroma. So, in next slide, medyo bigat, pero let's try to go through it together. So, when it comes to hard tables like this, ginagawa ko agad is tinitingnan ko muna how many divisions there are. So, I said kanina, there's the epithelial, there's the germ cell, and then there's the sex cord tumors. So, um, when we think of epithelial tumors, these are the most common in origin. And then when we think of germ cell tumors, these can be usually seen in young patients. I mean, kasi germ cells, di ba? Ito yung mga eggs. Usually, ubusan na naman eggs during menopause. So, more or less, dapat sa young patients to. And then finally, sex cord. So, these are the ones that are associated with hormones. So, I didn't take the time to discuss all of them in depth, and I just put the main the main characteristic of the different tumors. So for serous cystadenoma, it's the most common ovarian neoplasm, while serous cystadenocarcinoma would be the most common malignant ovarian neoplasm. So just a review, when we think of carcinoma or sarcoma, these are malignant with a few exceptions, such as melanoma and hepatocellular carcinoma. Hepatocellular carcinoma, actually carcinoma pala dun. Sorry. So yun nga, if it's just cystadenoma, it's benign. If it's cystadenocarcinoma, it's malignant. So usually the most common would be the serous cystadenoma and the serous cystadenocarcinoma. So usually mga tanong dito would be, what is the most common ovarian tumor seen in women? So epithelial tumors, or pwede rin serous cystadenoma. If they ask what's the most common malignant, serous cystadenocarcinoma. So basically, this is just pag sinabi kasing cyst, gland, so serous glands and mucinous glands. So rare ang mucinous cystadenocarcinoma and can be metastatic from the GI system. So there are glands there. So Brenner's tumors is parang sa wild card. If hindi ka familiar dyan, baka hindi mo isipin na nandito. Pero it just appears encapsulated with a coffee bean nuclei on H&E stain. So moving on to germ cell tumors. So as I said, when the patient presents as a young or as an adolescent, ito yung mga isipin nating tumors. And then, so this germinoma, important dito is adolescents, usually seen in adolescents, and then they have a fried egg appearance. And they produce HCG and LDH. And then I think we can lump together mature cystic and immature teratoma. From what we learned in histo, when we say a cell is mature, it's developed. It would be fully developed. It doesn't have any potential. And so it's part of it's either one of the three germ layers. So parang ito yung isa sa mga most common in young females. Ito yung mga may ngipin, may buhok, may taba, medyo malalaki din, pero these are benign. As opposed to immature, which are malignant. And since they're immature nga, they present with fetal tissues. Next would be yolk sac tumor. So these are hemorrhagic masses, and then they look like glomeruli, and these are called Shiver Duval bodies. They also produce AFP. So we have this germinoma that produces HCG and LDH, and we have yolk sac tumors that produce AFP. And then finally, the last part would be the sex cord tumors, which produce hormones. So most common would be the granulosa cell tumor. It's the most common malignant sex cord tumor, and it produces estrogen. Sorry, hindi ko na nalagay dito kasi explain ko, I mean, nakalagay na naman dito na it can produce large amounts of estrogen. So ito sa mga favorite na tinatanong actually. And yolk sac. So not as common would be the tecoma and the Sertoli Leydig cell. So the tecoma can also produce estrogen, but it's benign. And then the Sertoli Leydig cell will resemble testicular histology and it can produce androgens. And then palaging sinasabi itong fibroma ay Meiggs syndrome sa OB. So that's the trio of ovarian fibroma, ascites, and pleural effusion. So hopefully kahit makatugtong if ever. Kasi in the next slide, so this is a question from the Remeds 2020. And this is a question from the Written Revalida 2020. Are they the same question? Parang mukha, di ba? Exact na exact. So, um, there are chances talaga na instead of making new questions, kumuha na lang sila from yung current Written Revalida. If we're fortunate, maraming ganun. Pero it's also possible that they alter the question and ask for a different ovarian tumor. So we just have to be prepared. So next, we have this, umulit na naman to. So this is the question from Written Revalida Remeds 2020, and this was the question from Written Revalida 2020. So once again, same question. And then, sorry. So we have a premature baby, so 28 weeks age of gestation, and then after he was born, he was cyanotic and markedly dyspneic. And then they're just asking us, what should the following structures are poorly developed in this case? So from we have to have a clinical idea of what this disease is. And usually when we think of premature, we think of hyaline membrane disease or respiratory distress syndrome. And then the what's affected would be the pneumocyte type 2. It's not fully developed. There is not enough surfactant, as you can see here. Um, there are type 1, type 2, and alveolar macrophages seen in the respiratory system. So the type 1 pneumocytes are thin and squamous, and they're flat for optimum alveoli gas exchange. So these are the cells type 1. In between them would be the type 2 pneumocyte. It is cuboidal and clustered. It has two main functions. So two main functions. So it's a precursor for two cell types. So type 1 and type 2 pneumocytes. And they also secrete surfactant. Finally, the last cell in alveolar cell will be the alveolar macrophage. So from the name itself, macrophage, it is an immune cell that will phagocytize foreign bodies, and it will also release cytokines. Important concept to know here is in some cases, they would have hemosiderin within them. And then this would be a sign of heart failure. So these are called the heart failure cells. So connecting this to, so the surfactant would decrease alveolar surface tension and it would decrease alveolar collapse because as we learned from physio, the lungs have the tendency to collapse in on itself, and so this surfactant helps decrease that surface tension so that it doesn't collapse. So the main component, so ito biochem naman, dipalmitoyl phosphatidylcholine. Hindi ko na maalala yung structure pero sana nadaanan ni Robert. So just if ever matanong nila ano yung specific main component of surfactant. And then here, the synthesis starts at 20 weeks and then it achieves mature levels at 35 weeks. So important to because remember in OB, what we do to stimulate, to increase lung maturity would be to give corticosteroids. And the last week that we should give corticosteroids would be 34 weeks. This is the reasoning as to why we do that, because during the 35th week, the the fully developed na ang type 2 pneumocytes. So I also added the sorry, I also added the steroid dosage. So actually ito medyo important talaga eh. Very useful ang bit of knowledge na to kasi matatanong to a lot. So betamethasone 12 milligrams IM, 2 doses 24 hours apart. Or dexamethasone 6 milligrams IM, 4 doses 12 hours apart. So B12 224, D6 412. And then for Pedia, we can check the X-ray, which would show ground glass opacities, whiteout lung, or a collapsed lung. So next, itong question na to, mahirap talaga siya nung dinaanan natin sa written Revalida. Kasi ano eh, parang we don't really remember the cystic changes that occur in a kidney. Mas naalala natin yung mga nephritic, nephrotic, AKI, CKD. I mean, CKD, andyan na yan. Pero we don't know what it would look like. So, um, if you don't have a handy Robbins nearby that will tell you the exact answer, kasi itong excerpt galing sa Robbins, saktong-sakto, numerous cortical and medullary renal cyst. The cyst measures 0.1 to 4 cm in diameter. So, pasok na pasok siya dyan. Pero, of course, hindi mo naman memorize yan kasi sobrang isang sentence lang yan sa, I'd say, hundreds of pages sa Robbins. As in, hinanap ko talaga yan, mahirap hanapin. So, what we do is, we sort of try to investigate the choices that we have. So, una kong rule out was letter C. Kasi why would there be multiple cysts on the liver? Tapos naalala ko pa na may certain congenital disease that would present with cysts both in the kidney and in the liver. And yung disease na yon is polycystic kidney disease. Parang weird, no? Kasi polycystic kidney disease pero may cyst din siya sa liver. Pero yun yung pinpertain ng C. So, na-rule out ko na. So, D, the normal left kidney but enlarged right kidney with variably sized cysts. So, I thought to myself, bakit kaya yung left kidney normal pero yung right enlarged? Parang, would that match the description of a patient with chronic hemodialysis and chronic renal failure? Probably not. Kasi, I mean, limited lang naman knowledge ko. So, wala akong alam na parang wala akong alam na way kung saan mag-cause ng isang normal kidney tsaka isang enlarged kidney yung chronic hemodialysis. Parang isipin mo dyan is ano, di ba? Parang stones or um, trauma, infection, anything na specific talaga sa isang kidney. So, tinanggal ko na yun. So, yung A tsaka B na lang talaga yung pinagpipilian ko. And naalala ko from Med 1, one of the ways to differentiate AKI from CKD is we can do a kidney ultrasound and we can see if the kidneys are contracted or small. Because this would be more of a chronic change, which is consistent with chronic renal failure. So, binalikan ko yung Harrison's, tapos nakita ko tong excerpt na to. So, because it takes time for kidneys to shrink as a result of chronic disease, the finding of bilaterally small kidneys supports the diagnosis of CKD of a long-standing duration. So, minsan talaga, I know, mahirap pag-isipan, lalo na daming items, daming pressure, pagod ka na sa kakabasa. Pero, sometimes you really have to take the time to figure out ano sa mga choices ang best. So, next, this one is a question that was repeated. Kidney ulit. This is the question from the written Revalida Remeds 2020, and this was taken from the written Revalida 2020. So basically, they're asking the same thing. With that, we should go back to our lesson in histo. Medyo basic pero madaling ma-confuse. So when we say diffuse, more than 50% or all of the glomeruli that we have sampled from the biopsy. When we say focal, less than 50% of all the glomeruli we have sampled. So these pertain to the number of glomeruli that are affected. Versus itong global and segmental, where we only check to see how much of the glomeruli or what parts of the glomeruli are affected. So global, the whole glomeruli. Segmental, only a portion of the glomeruli. So going back to the question, so two of the glomeruli have glomerular base. Two out of 10 glomeruli have the thickening. So that would be focal, kasi not all. And then it said only a part of the glomeruli. Sorry. So that would mean it's not global kasi it's not all of the glomeruli. So we have another medyo intimidating table, pero important din to kasi we have to be comfortable with differentiating nephritic and nephrotic. So if you're gonna remember if yung main priority muna natin would be to be able to differentiate nephritic from nephrotic. So nephritic is an inflammatory process. There would be hypertension, hematuria, oliguria, and azotemia. While for nephrotic, there is more of a proteinuria, greater than 3 grams per day. So important yung number na yun. There's massive proteinuria. There is, because there is loss of protein nga, there is decreased plasma oncotic pressure. So that can cause edema. And there will also be hyperlipidemia. If you want to go to the specific acronym, ito siya, Faro and nephrotic. Pero honestly, okay ka na sa just these descriptions. Kasi usually, pag magbigay sila ng case na mahaba, isipin mo agad, is it nephritic? Is it nephrotic? Pag nakita mo may edema, mag-lean ka towards nephrotic. If makita mo may hypertension, oliguria, mag-lean ka towards nephritic. Pero they can still coexist together. Kaya nakakalito din. And then, kasi usually yung choices, papakita nila would be these diseases. Usually, kung mabait sila, may isang choice na kakaiba. Parang tatlong nephritic or isang nephrotic lang, baka nephrotic lang talaga yung hinahanap nila. Pero kung gusto nila pahirapan kayo, puro nephritic. And then, nagbigay sila ng trigger word. So, the trigger words are here. So, when you say acute post-streptococcal glomerulonephritis, so post-strep, after an infection with strep, gram positive, group A streptococcus or strep pyogenes. It usually comes 2 to 4 weeks after the upper respiratory tract infections, as opposed to IgA nephropathy, which occurs concurrently with the respiratory or GI tract infection. So RPGN, this would be parang sobrang lala ng patient agad. Ang bilis bumaba ng GFR niya and malala yung symptoms niya. And then there will be crescents. So when we think of diffuse progressive glomerulonephritis, we think of SLE. But it can present with nephrotic and nephritic. And then finally, si membranoproliferative. So this can also present as nephritic and nephrotic, pero more often than not, since it's nephritic, it would present with tram tracking. So pag nabasa mo tram tracking sa question, ito na usually agad yung question, ay yung sagot. As opposed to nephrotic, ito yung parang mas konti sila eh. Like there's only really 3 na kailangan mo alalahin. And similar pa si minimal change disease and si focal segmental glomerulosclerosis. It's just na one is good prognosis, more common in children, improves with steroids, as opposed to focal segmental, which is more common in adults, pwede siya mag-progress to CKD and inconsistent response to steroids. Si membranous, trigger here would be the spike and domes. And then for diabetic, so hereditary diabetic would usually present with a nephrotic. Look for the Kimmel-Stale-Wilson lesions. Hindi ko na masyadong ma-describe siya, sorry. Pero hopefully, yun yung sabihin nila, hindi nila i-describe. If ever, try ko na lang habulin yung description niya later. So another hard question involving the kidney. So mahirap tong question na to kasi very similar ang hyperpara and you think of Paget's disease of the bone, lalo na if the symptoms they gave you would be osteoclastic bone resorption, delayed matrix mineralization, osteoclerosis, and osteoporosis. Parang yung main thing na napaisip ako bakit chronic renal disease would be yung growth retardation. Kasi ano the mas malala ang effects ng chronic renal disease because the kidney has so many jobs. 'Di ba kaya pag may AKI ka or CKD, uh, emergency na yun, kailangan i-admit, kailangan i-resuscitate kasi a lot of these problems can happen due to kidney disease. So additionally, parang same as the kidney, other systems that would really present with so many adverse effects would be the thyroid and the liver. So keep that in mind na lang. Sorry guys, mahirap talaga yung question na to eh. So next question, so we go to hematology. Um, so tinatanong lang nila ano yung mechanism of anemia due to red cell hemolysis. So when we talk about red cell hemolysis, isipin mo agad, increased red cell destruction. And you're right naman, tama. Pero yung problema, walang clear winner sa mga sagot na to. Parang mabagdadalawang isip ka pa na increased blood loss. Kasi, di ba, parang blood loss can mean similarly to red cell hemolysis. Destruction, blood loss. Pero when it comes to Robbins and pathologists, iba silang mechanism. So there are three mechanisms for anemia. The one here would be increased red cell destruction or hemolysis, and the other two would be blood loss and decreased red cell production. Usually, madaling ma-differentiate ang decreased production from hemolysis. It's just na catch off guard lang tayo sa blood loss. So I put this table na so that you can see the different mechanisms, the specific mechanisms of red cell hemolysis. Ito nakabox yung increased sequestration. So another hematology question. Important dito, alam mo yung, sorry. Okay. Alam mo yung definition of thalassemia. So when you have thalassemia, it means na you have a genetic problem which prevents you from making normal hemoglobin. So what is hemoglobin again? So hemoglobin is this molecule that is used to transport oxygen. So it has 4 globin chains. So the normal adult hemoglobin would have 2 alpha 1, two alpha chains and 2 beta chains. This would be HB. This would correspond to HbA. And then in beta thalassemia, since there cannot be production of beta globin, so kulang to. It is replaced instead by the gamma chain. So the gamma chain is another globin, and then once we have an alpha and a gamma globin chain, hindi na siya hemoglobin A. It becomes hemoglobin F or fetal hemoglobin. So this change is parang an adaptation kasi since it cannot produce enough beta globins, gagawa na lang siya ng gamma, and there will be an increased hemoglobin F instead. So important mnemonic would be the tails kasi thalassemia is part of the group of diseases that would present with microcytic hypochromic anemia. So tails is an acronym for thalassemia, ACD or anemia of chronic disease, IDA, lead poisoning, and sideroblastic anemia. So how do we say if the patient is microcytic or is the blood cells are microcytic or hypochromic? So we get the mean cell volume and the mean cell hemoglobin concentration. So these are usually given pero minsan pinapakompute pero feel ko hindi naman. So normal value is 80 to 20. Normal value would be 38 to 36 usually. So if they're decreased, it means that there is anemia, microcytic hypochromic. So if ever tinatanong how to differentiate IDA and thalassemia, we can use the Mentzner index where we divide the mean cell volume by the RBC count. So if the value is greater than 13, meaning equally decreased ang mean cell volume and the RBC count, because in immune deficiency anemia, there is decreased production of RBC And there's also production of small RBCs, so both mababa. It will be greater than 13. While for thalassemia, there is normal production of RBC, but because there is no beta chain, um, they produce smaller. Kaya less than 13 siya kasi mas malaki yung denominator, which is the RBC count. So, another share this lucky Cachuela kasi we need all the help we need. So, share nyo to guys. And the reason kung bakit ko sinama to kasi yung next question, kinuha ko, ay, na tinanong sa Remeds 2020 is similar to what Neil discussed yesterday. So, kinuha ko na slides niya kasi, I mean, para mas ma-reinforce. Hindi naman, ay, sorry Neil, di ako nagpaalam sa'yo. Sana okay lang. So, like what Neil said kanina, there are zones and there are lobes. And then when we talk about prostatic carcinoma, we think of the three P's. Sinabi Neil yung kahapon, three P's. So prostate CA, posterior lobe, and then the peripheral zone, if we're talking about zones. So here again are the lobes. There's the anterior with fibromuscular and no glands. There's the medial with the glands. And then there's the posterior, which the prostate CA arises from. So So this table helps us differentiate between BPH and prostate CA. So next, a 39-year-old woman experiences sudden onset of chest pain. She is a febrile but tachycardic and hypotensive. And her ECG shows an ST segment elevation with a Q wave. The left circumflex artery shows marked coronary occlusion and her underlying condition is most likely. So, isipin natin agad, anong sakit sa patient? So, the patient natin is suffering from yun nga, ST elevation myocardial infarction. So if you look at it the pathological way, we always think of the main cause, which is atherosclerosis. So atherosclerosis when there's a buildup of cholesterol, plaques, and intima. So it's more of an inflammatory process that starts with endothelial cell dysfunction and damage. So this causes an inflammation or inflammatory response that would yeah, that would attract macrophages and also lipoproteins such as LDL to the site. And then when this continuing inflammation will cause the fatty streak formation. So there will be a fatty streak, there will be foam cells, and there will be lipid-laden macrophages. And then because of this overwhelming inflammation, there's also intimal migration already. And so this is where we get the fibrous plaque. If this plaque can dislodge and move further up and obstruct any of the important coronary vessels, that is what would cause the ST elevation myocardial infarction. So tinatanong lang ni dito what underlying condition is a risk factor. So the risk factors are here. So diabetes is also associated with hyperlipidemia. Kaya, and then more lipids, more fuel for this fatty streak formation. So that is the main answer. In Sapato, the more diseases you know, the more you can sort of rule it out. Like for example, kung alam mo yung AML is a blood CA with greater than 20% myeloblasts, parang isipin mo wala naman yung masyadong connection talaga sa ST elevation. And then if you knew Marfan syndrome, which is a genetic connective tissue disorder, and then yung most common effect niya sa heart would be acute aortic dissection, hindi mo siya isipin in this case. So it's either between chronic alcoholism and diabetes mellitus. So mas strong ang relation ng diabetes mellitus. That's why yun yung sagot. So next, ito yung medyo mahirap din to from the written Revalida. So they gave us the data that a patient is a woman who recently gave birth. Important yon. And then yung symptoms niya would be sudden onset of dyspnea and hypotension. And then she later developed seizures and became comatose. Tinatanong nila, ano yung morphologic changes that can be seen in this case? So in this case, specifically, especially since the patient recently gave birth, she presented with sudden dyspnea and hypotension. So as you can see here, it's one of the hallmarks of a pulmonary embolism. So this is an acronym that can help us remember ano yung different types of pulmonary emboli. So fat. So it's fat, air, thrombus, bacteria, amniotic fluid, and tumors. So here I added a few words to help us differentiate what situations would more likely give what kind of emboli. So for fat, it would be long bone fractures and liposuction. For air, it would be nitrogen bubbles in ascending divers. So ito yung parang bends. It can also be iatrogenic if there is air inside the syringe when they inject blood or inject medication. That could cause an air emboli, thrombus, bacteria, and then amniotic fluid, which is present in our patient since she just gave birth. So this picture is the laminated swirls of squamous cells that were seen in the pulmonary arteriole. Actually, from the choice itself, parang sobrang halata na niya kasi may pulmonary arteriole kasama. Siya pa yung longest. I mean, minsan pag wala na talaga akong maisip, ubos na yung capacity to think, kinuha ko na lang yung pinakamahabang sagot. Pero talagang pag ano na yun guys, pag wala na talaga kayong capacity. So next question. So simple question lang, what are the following are more common in left-sided heart failure compared to right-sided heart failure? So we just have to remember our anatomy, our circulation. So the right side of the heart receives unoxygenated blood from the systemic circulation. So this would come from the inferior vena cava and the superior vena cava. So that's why it would present with elevated JVP, and also peripheral edema and hepatomegaly. While if it's a left-sided heart failure, so the left side receives oxygenated blood from the pulmonary system. So since the heart loses its pumping ability, uh, the problems that would be presented would be more or less yung pulmonary symptoms. Sorry. So next one, a 59-year-old male diagnosed. This is from the written Revada Meds 2020. So the keywords here would be colon cancer. There was 10 pounds weight loss with progressive loss of body fat and lean muscle. So simple question lang to. Tinatanong niya, what do you call this effect of cancer? And then parang mahilig talaga yung pato magtanong ng so many words na hindi natin familiar, hindi natin alam. Pero usually may isang word talaga na familiar sa atin. And that's ka-check siya. So for the benefit, nilagay ko na rin lahat ng meaning ng other words. So in case umulit siya, at least alam mong baka hindi talaga yan. So, yeah. So this another question. Ito mahirap talaga to. It's from the written revisory meds last year. And parang there's no way, wala akong maisip na way paano siya like let's say for example, hindi mo nabasa tong small excerpt na to from Robbins. Parang ang hirap maisip ano yung magiging microscopic manifestation of anoxic neuronal changes in the brain. I mean, I guess pwede mo i-rule out yung fat droplets, I guess, kasi ano kinalaman ng fat. And then usually pag sinabing granuloma and caseating necrosis, isipin mo ang TB, lalo na pag caseating necrosis, which hindi naman all anoxic neuronal changes in the brain will occur. So yung choices mo either A or C. So 50-50% chance na lang talaga. Pero it turns out yung answer from Robbins would be yun nga, yung diffuse eosinophilia of neurons. And that's why they call it red neurons. So with that, hopefully natuto kayo. So good luck guys. If may questions pa kayong added, pwede nyo lang ako i-message if ever.
Yay! Thank you, Bert.